Hey everyone, Vic Tapson here. Great to have you all here for this chest webinar. I'm going to give people a few minutes to get into the lobby, make sure. I know some people might get on a minute late, so we'll give you a couple of seconds here to get on board before we formally start here. But we're excited about the program. I think we have something like 700 people registered, which is fantastic. So we're excited about all the interest in pulmonary embolism. So having said that, I think giving people a little bit of time to get in. So let's start. I'm Vic Tapson. I'm VP of Medical Affairs at Inari, also a professor of medicine at Cedars-Sinai and pulmonary critical care. And I'm really excited to do this webinar in collaboration with the ACCP. I think I've been at every ACCP meeting for the past 25 years, longer actually since I was a fellow, until the pandemic, that is. So always a great meeting, always great to see friends around the world in pulmonary and some in cardiology too. So ACCP is a super meeting every October. Great expert lineup today for bloodless thrombectomy for acute PE. Evidence and future directions. And we've got Parth Raleigh, pulmonary critical care superstar from Temple. Parth, great to have you here.
Oh, my pleasure, Vic. Always.
We've got Robert Goldberg, pulmonary critical care from here in Southern California at Mission Viejo. Rob, great to have you.
Thank you. Thank you for having me.
And I think we got Jim Horowitz. Jim, as always, is in the trenches somewhere. He's got a case to present and some data for us. We're hoping he gets on here. If he doesn't, we're going to miss him. But we'll give him a hard time another time. But Jim always adds a lot to a program. So if he doesn't make it, Jim, just as I was complimenting you, you made it.
Just got here.
Man, timely. Well, I hope you got that guy intubated or whatever was going on there, Jim. Great to have you. Well, listen, so I'm going to start off a couple of slides here, folks, and just a couple quick things, just some disclosures. And I'm a pulmonologist. Why did I join Inari? Maybe some people might be interested in that. Very quickly, there's some Inari principles that I really like. Medical education, like this webinar. Tons of information and tons of effort in the medical education realm. Robin Lucy, who's on with us, is one of the superstars in our medical education area. Product development is a big deal. Rather than getting something through the FDA and starting to market it and just resting on the laurels, continued technology improvements, 60 plus engineers, fantastic product line and development. Clinical research is very important, obviously, at Inari. We're doing big registries, 800 patients in the FLASH registry now. Jim's going to talk about that a little bit. A randomized trial coming up. Program building is really big. VTE excellence. We have a meeting coming up in a couple of weeks with 25 VTE coordinators who are working at various programs with VTE. So all these four pillars are important and make things really exciting at Inari right now. I'm going to advance my slide here. I just thought I'd show this historic slide real quick. You all know Laser Greenfield. He came up with a Greenfield filter in 1973. 1971, he published data on transvenous pulmonary embolectomy by catheter device 50 years ago. And now we're picking up the ball. We're picking up the ball for catheter embolectomy. The FlowTriever system we'll talk about today, FlowTriever 24, there's the nitinol discs there. This toolkit that we have, I'm not going to go into detail here, but the FlowTriever catheters, the curve to help get the PA, the FlowSaver blood return system, bloodless thrombectomy. We didn't used to have this available. We didn't have it available when we were doing some of the FLASH registry cases, but now we can save blood, not lose blood, and flow stasis for closing. So there's lots of cool things here. Many of you may not have seen this device or scrubbed in one of these cases before. Bottom line, you do a right heart cath, get the wire through the target clot, the dilator in place, you advance the FlowTriever, the wire into the clot, dilator's taken out, you open the syringe stopcock to get this high flow aspiration, suction out the clot. You might suction out some blood too, and the FlowSaver comes in handy. If there's still clot there, and sometimes there is, you can utilize these nitinol discs. So you advance the catheter through, as it's retracted, these discs expand, engage the thrombus, and can pull it out. So again, not always needed, but sometimes. Quick point here, you all remember Passul's law. Passul's law, bigger radius, better flow. Radius is proportional to flow, to the fourth power. So 24 French can get good flow, 150 cc's per second for the Triever 24, and much less flow for much smaller devices. So I think that's a big part of what the advantage is here. I could spend some time on product development here. It's phenomenal what's gone on in just 5 or 6 years here with FlowTriever for PE, ClotTriever for DVT. I won't go through detail. Just want to just flash that up there. Our engineers are just cranking things out, new ideas, new ways to improve things. I want to show us just a study really quick here, just make mention of something really quick here. And mortality in acute PE, Cecilia Beccattini. She's probably the queen of meta-analyses for PE. And this one I really like. This one basically just shows us mortality rates here in acute PE. And if you look here, we know high risk PE, but look at the mortality for intermediate high risk PE. Death due to PE at 30 days, 4.8%. 10 times higher than for low risk PE. And look at intermediate low risk PE. Mortality 2.1%. Sounds pretty low, but it's due to PE at 30 days, 4 times higher than for low risk PE. Intermediate high risk PE, we looked at, David Jimenez and I and some others looked at this even higher death rate due to PE at 30 days, 7.2%. Well, 1 out of 12 patients, that's too many. So interesting data. Intermediate high risk PE and even intermediate low risk PE, higher death rate than for low risk PE. Some of the registries out there, we get some great data from the PERT registries. 30-day mortality in the Schultz paper was 15% for intermediate low and about the same for medium high risk. Now that's all-cause mortality, not PE-related mortality. And some of these registries include some really sick patients, heart failure, cancer, bleeding problems, trauma, et cetera. So, but bottom line is PE-related death, it may be under 10%, but it's close. It's close. I like to make this point that our risk stratification isn't perfect yet. Prognostic significance of DVT when you present with PE. If you've got PE and there's still clot in your leg, which occurs in about half the time, the PE-related 90-day mortality on the far right there, 4 times higher if you got proximal DVT. And if you want to just take a quick look at the hazard ratio there and the confidence intervals, it's somewhere between 1.6 and 11.25. Where is it? I don't know, but it's up there. So if you got clot left in your leg, that's important. But what do we do about it? We really don't have a standard plan. Risk stratification isn't perfect. That's what my main point there. ACCP has done a great job with guidelines over the years. This one was published, as you guys know, just a couple of weeks ago. It's pretty similar to what we saw in August, but this is the antithrombotic therapy guideline for catheter-assisted thrombus removal. If you've got acute PE with hypotension, so massive PE, high-risk PE, and you've got a high bleeding risk, and you failed thrombolysis, or shock likely to cause death before lysis can take effect, and you've got the expertise, then catheter-directed thrombus removal is suggested. So I'm kind of wondering if we need to be waiting for all these things, why not include someone that doesn't have a high bleed risk? And Jim's going to talk about the FLASH registry, and we'll see what you think about the FLASH data. And maybe if the FLASH data, when published, and subsequent data, maybe that will help change guidelines ultimately, because we got a lot of data here Jim's going to show. Meaningful goals other than mortality, there's some here. I'm not going to list them all. Recurrent VT, length of stay, ICU length of stay, CTEPH, et cetera, et cetera. It's more than just mortality. So we need to work on these things and try to find ways to see if we can reduce some of these other bad outcomes. Finally, let's reduce the death rate. These pictures to me are pretty impressive. And I think the data are even more impressive than the pictures. Finally, DVT, here's the clot retriever catheter, coring element collection bag. Pretty cool things being done with this device. Acute DVT, even some chronic cases we've seen recently that have been pretty mind-boggling with good preservation of the valves. So I ran through that stuff pretty quickly because I want to get to our experts here. But here we go. Jim, Parth, and Rob Goldberg. We're going to start off with Parth Raleigh. I'm going to stop sharing here now. And Parth, we're really eager to hear your case.
Oh, no, thank you, Vic. This is fantastic overview of the NRA data. That's wonderful. And I think whatever I'm going to say is going to echo a lot Vic started. Before I go to my disclosure, my biggest disclosure that I fall in love with the PE world, a lot of credit goes to Vic Tapson. So that's my open disclosures. So
very kind.
Here are my other few disclosures. Then let's dig right into the case. And I think this is one of those cases early on in my exposure to this device that made me fall into love with this, why I so much value this device and the technology. And I hope that I feel connected with all of you, because this is not some uncommon case. This is what we see in the ICUs or in the critical care world all the time. So this was a 76-year-old male who was on AFib, on Coumadin, has CKD, had a mechanical fall. He lives in middle of Pennsylvania, a lot of snow. He just slipped and fell. Comes to the hospital, has a subrecurrent hemorrhage. Obviously, Coumadin gets stopped, gets observed for a couple of days. and taken off concomitant for a few months and gets discharged home. As expected, comes back to the ER in next couple of days, needing 5 liters of oxygen. Mind you, this guy is not on baseline oxygen, is not a smoker, he's not a COPD, or not all of the above. So new oxygen requirement. And obviously, he has big clots, and this is how his RV looks like. If you kind of see that there is a contrast on the right side, but there is much less contrast on the left side, and even the left atrium is even pretty small. So that means that your clot burden is super high. The image that you are here seeing is a dual energy CAT scans that we have at Temple, so we are a little lucky. But this is a very bad looking RV, and obviously he has clots. He has hemorrhage into his brain parenchyma. Not an expert, but he has subrecurrent hemorrhage that he had a couple of days ago. Nothing worse than previously when he represented in a couple of days. This is what happens. The patient was at outside hospital, neurosurgery gets consulted, and they absolutely say that you cannot anticoagulate this patient because he has recent anticoagulation. Obviously, no disclosure. Surgeons don't think about the lungs, but from brain perspective, they said you cannot anticoagulate this patient. Obviously, echo had a massively dilated RV. McConnell's sign was positive. He was stroke positive, BNP positive, lactic acid positive. As Vic kind of said, the DVT is a big important part of your risk stratification and decision making. Had a lot of clots in his leg, left common femoral, popliteal DVTs. Decision to transfer to Temple University after the PERT discussion. So we got called, and mind you, this was a tertiary care center who called us, and then we said we got to do something about this guy. So we got him over at Temple. By the time he arrived, his oxygen needs have gone up from 5 liters to 40 liters of oxygen. So he was on a high flow with 100% FiO2. He was also started on a little bit of Leofed. He was on like not high dose, but he was on 1 mg of Leofed. His systolic blood pressure was still okay. Heart rate was 98, 99, very symptomatic, as you can imagine. And how do you classify this patient? So I think first thing that I think we kind of said that it's not perfect, and this is why it's not perfect, because if you look at the latest ESC classification and try to put all the biomarkers and PASI scores, and this guy is somewhere between high and intermediate high risk. He's kind of swinging back. I mean, he's getting on pressors. He was not on it. We don't even consider how much oxygen he's on in part of risk stratification tool. I mean, 40 liters of oxygen was not even available 20 years ago. So I think this guy his pendulum is swinging, and this guy is kind of like swinging from hemodynamically unstable to mildly stable when he arrives at our ICU. First thing, treat or not to treat. And I think I will open it to my panelists. What do you think? What's your hunch say as an intensive? Should you sit on it or should you do something about it? I'll start with Vic and Robert and Jim. Do you guys have any?
Sure. Yeah, that sounds like Shakespeare. Treat or not treat. I like that. Well, one thing I'm going to call attention to real quick, Parth Raleigh wrote a beautiful paper on transferring patients with PE. We could spend an hour talking about that. We won't. If you take a look at that paper, Chuck Ross is on it, some of their PERT folks, but really nice paper on the nuances of transferring someone that's sick. Well, I'm concerned about this guy, and yeah, we're not going to give this guy lytics. I mean, if this guy had a abdominal surgery 2 weeks ago, you might take a chance, call the abdominal surgeon and say, we got to do this. Intracranial hemorrhage, you just can't mess with thrombolytics. So we're done there. Yeah, I'd want to treat. This guy's concerning me a lot. Heart rate's not that fast, but he's on some Levofed. Boy, that's all I need. His lactate was up, all his biomarkers. I'm worried about this guy. I would definitely be aggressive here. What about Rob and Jim?
I completely agree. This patient is showing multiple signs of being quite ill, even though he's not quite in fulminant shock. He's only on one of Levofed. He's on in that pre-shock state that probably has underlying shock that's going to be developing. His right heart's already failing.
Okay. Jim,
any thoughts?
Yeah, coming to you live from the supply room in the Bellevue CCU.
I love it.
Yeah, always an easy day, right?
Yeah.
You know, as you guys were saying, this is somebody who is sick. How sick are they? Well, they're on some pressor. And the question would be, if you started doing some further risk stratification, which we'll talk about later, maybe you would start to see that on an echo, his VTI is low, and that indicates a lower cardiac output. Whereas you'll see when we talk about flash data later, there's lots of folks like this, even less clinically ill than this, that when you put the catheter up and check a cardiac index, it's less than 2, and they're actually in subclinical shock.
Great point.
So I think a lot of folks are sicker than we think.
Great point.
right? So I think I'm glad that we all are getting into the same hunch that we want to treat. I think what next we're gonna do is something that is more controversial. So let's keep advancing. So first thing that we have as a part of our process, that in our template, we put this like TPA absolute and relative criteria, right? So this guy, TPA, you want to think about it, but absolutely not, given that he has such a big ICH. That guy is barely not on anticoagulation right now. TPA is out of the window. Obviously, he also meets into relative criteria being old, because we know that people with old and people who have AKI or CKD tends to bleed a lot, right? So that's one thing which we think should be out of, it's not an option, right? How about TPA and ICH overall, right? So there is a PECH score. There are not many scores out there which kind of predicts intracranial hemorrhage in patients who are getting TPA. One of them is out there, developed by Chatterjee and the group, along with some of the colleagues at Penn. And this is only one of the best scores out there. But even in that, he puts at a high bleeding risk. Again, our patient already has an intracranial hemorrhage, but even if not, with his age and recent stroke, he's very high risk for further worsening ICH, I should say. Other score that Dr. Jimenez, and along with that group, I was lucky enough to be development of this group, where we actually developed this score to kind of look into the risk of major bleeding. So we are not talking about ICH, now we are shifting the gear TPA and the major bleeding. And these are the points that we came up from the REAT registry, and then it was externally validated in Command VT registry. If you put him through that, he's still very high risk. His risk is like 4. So this guy meets all the criteria. And when we talk about TP and major bleeding, we are talking about 25 to 30% of bleeding in general. So in general, even if he doesn't have ICH, this guy would be in a very high risk for bleeding in general. Okay. Call the surgeons, right? So I think one question I always get asked is like, yeah, when you can't hyperonize somebody or can't give TPA, the guideline says go for surgical embolectomy. Have a conversation with your surgeon. When somebody goes down a cardiopulmonary bypass, they need massive tons of heparin as a bolus to go through an embolectomy. So yes, on paper, on guideline paper, that may say that fine, if you can give TPA, do an embolectomy. But in real world, doing an embolectomy on a guy who is an ICH, putting some general anesthesia and then give him a large dose of heparin to go on a cardiopulmonary bypass, it's almost like next to impossible. So call the surgeon, great idea, but I don't think it would have worked at anywhere with this guy. So this is what I was thinking when I was preparing the slides, that what would have happened to this guy if we had presented in different decades, right? So if you had presented between the early 1990s or 2000, there was no high flow there. So I think Jim Horowitz, who was about to intubate the patient, would have easily intubated this patient, and then patient would have cardiac arrest, okay? If you move the clock forward up to 2000, 2010, we can talk about different doses of TPA, different routes of TPA, maybe an IVC filter to prevent a second hit, blah, 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 blah. Advanced at 2010, 2020, CDT, different catheter devices out there, or you can try to convince your surgeons. But again, all of them, as I think I have kind of shown through, is not without a risk. And I think in 2021, if you have your PERT, you get people together and we perform suction embolectomy for this patient. And patient did great. He actually became our one of our PERT representative papers. So he is on our Temple website. He did great. His oxygen requirements came down. He went back to his life and never needed even to get a filter. And he's doing well as of today. And he was very happy that I was presenting his case. So to end it up, how is this device and catheter treatments are making option in my mind, right? So I think we kind of mentioned that you can see the effects immediately. RV-12V ratio, even the hemodynamics, your PA pressure drops, your heart rate improves on table. So once the patient is in cath lab or the IR suite, you can rest assured the results will be immediate, right? To a certain degree, I mean, we talk about physiology, but in my mind, PE is a mechanical problem that needs a mechanical fix. So if you have a blockage in the pipe, remove the block and things will be fine, right? Single session, less ICU needs. We have had patients since we have been using devices. The patient comes from floor, goes back to floor, and I don't worry about them bringing them from ICU. With support of PERT, I can do it even in high-risk cases. Like you can do it in massive cases. Obviously, we have a registry for that. We have data to do that. You just need a good setup to do that. Bleeding risk, there's no reason to shrug your shoulder and say, I could not do anything. I mean, absolutely, you can do something for your patient because the mortality for intermediate low risk and intermediate high risk PE is also unacceptable. To me, PE is a preventable cause of death. Post-fail thrombolysis. So if you give TPA, which is fine, you still have an option to go back and remove the rest of the clots with this device. And big thing I think it has changed is that you can also treat DVTs with the similar devices with the clot trigger. And even if you don't do clot trigger in the same setting, absolutely there is no need to put an IVC filter to prevent a second hit hypothesis. So I think this is where I would stop. I think this catheter has changed the way I approach the case with the PE.
Parth, that was a great presentation, great case. A lot of lessons in that case. Hey, one thing I think we should do after Jim presents the flash data, just everybody in the audience should think about this case again and say, suppose there was no bleed risk at all. This patient had elevated lactate, biomarkers, was on a little Levofed, bad looking RV. Would you consider doing FlowTriever, or maybe even though there wasn't a bleed risk, perhaps something to think about? But let's see, Jim. I think you're going to share the slides now. Do you have them in front of you there?
I'm stuck in this supply room, so Parth, can you keep showing your slides?
Absolutely, I can. One second.
I'm literally rolling a wow around the ICUs trying to find some place that's relatively quiet. And I did find like the clean supply, or the medicine room, and then all of a sudden the ice maker went off for 10 minutes. I had to run out of there.
Jim, you're the quintessential in the trenches critical care guy. It's unbelievable.
Always something.
Love
Okay,
it.
Jim, let me know when you want me to advance the slide. Just say next and I'll
Thanks,
advance.
This is me getting revenge on you for saying that I would intubate the patient and they would code.
Okay.
So now you have to be my slide advancer.
Absolutely.
So, I think people have hinted at a lot of this. We talk about traditional risk stratification. Maybe we're asking the wrong questions. So typically we think, well, is this one of the few PE patients who's going to die or decompensate immediately? And then we always think, does the risk of short-term mortality from PE outweigh the risk of bleeding from thrombolysis? So for those of you that have been involved in PE work, for back when the days we only had CDT, that was what we always talked about. Well, the person's sick and we can do CDT, but if we do CDT, then we have to wait and see what happens and make sure they don't bleed. And back when we used to do 24 hours, Parth talked about a single session procedure. That's something that like IR folks talk about that isn't really in the lexicon of critical care folks. But what that means is that you do the whole treatment on the table. You don't have that up to 24 hours of waiting with CDT in the ICU for something bad to happen. So my record, in fact, back in 2014 or 15 is somebody bled at hour 23. So then there was a whole disaster, lots of transfusions, lots of problems. And then I had to stop heparin, which is the only treatment that has a class 1 indication. And so that's why the traditional risk stratification was, CDT risk of bleeding versus this low short-term mortality, but post-P mortality of 27% at 30 days. So I think we have to rethink risk stratification now that there's new devices out there. Go next slide. So if you look at the overall all-cause mortality in PE patients, in the PERT registry, it's 10%. This is all comers, 5,000 patients. Schultz, 15%. The MGH paper, almost 12%. And ICOPER, 12.5. Next slide. And then looking at high-risk patients, look at these numbers. A quarter of patients to half of patients dying in the first 30 days. So not necessarily even in the first day, but in the first 30 days. So that really changes how we risk stratify patients. Next slide. And as I mentioned, one of the things that make FLASH so special was even though it is a registry, there was a focus on hemodynamics, which is a new thing for the PE field. It's some sort of a mainstay of cardiac critical trials, but new to PE. And why is that important? Because we found a lot of really interesting things. I mentioned this idea of subclinical shock. So basically, we'll talk about FLASH in a minute, but this is a secondary analysis of FLASH. And they basically scored everyone, did their ESC risk score and their SPESI before the therapy was initiated. And if you look down at the two slides, you'll see that up about 20% of patients with low risk for both risk scores, when you put them on the table, actually had a cardiac index less than 2. So they're in, whether you want to call it cardiogenic or obstructive shock, they are sick. And the risk scores maybe aren't telling us all we need to know. Next slide. And I always argue, if this was a heart failure patient and you saw that number, you'd put in a balloon pump and there wouldn't be a big fight about it. So FLASH is the largest prospective data set advancing the treatment of PE. So it's a multi-center prospective registry to see the safety and effectiveness of FlowTriever in a real world scenario. So this isn't just a very small splinter of high risk summoning patients. This is real world, and they're following them out to 6 months. So originally it was meant to be 500 patients, and now we've gone up to say we're going to do 1,000 patients, intermediate high risk, and we added sites in both the US and then now in Europe. And the primary endpoint was device-related mortality, major bleeding, and intraprocedural device or procedure-related adverse events, including deterioration and device-related events. And that's one of the big things people were concerned about was is this big device going to cause problems physically navigating through the heart? So as of the TCT update in, I think, November, there were 500 enrolled patients at 26 sites with 6-month follow-up data. Next slide. So basically, what did we learn? Well, first of all, the patients that were in the study were sick. They were extremely sick, and therefore they accurately represent the high end of PE. So if you look down below, 40% of patients had lytics contraindicated, and this is real life. there's a lot of patients that have one of these things that Parth listed that is a contraindication to TP of any kind. And if you look on the right at the patients themselves, 31 or 6% were high risk or massive, and 94% were intermediate risk. So this is a sick group of patients, and again, 31 massive PE patients. Next slide. And some of the things that we looked at were access site complications, as I mentioned, and there were only 2 out of 500, so that's very, very great. And then the estimated blood loss was 260 cc's. And if you talk to the cath or IR people who do these cases, their blood loss tends to decrease once they get more familiar with the device, especially now that they have the flow saver to collect the blood. But that's for another day. Adjunctive therapy was only used in 4%. And that means that they did well with flow treatment, didn't have to move on to some other device or ECMO. And then again, here, ICU length of stay is essentially nil in this group. Next slide. And that ICU stay is a really important point, especially these days, because no matter where you are in the country, 30% of your ICU beds are filled with COVID patients. And most ICUs are at capacity. There's no staffing, there's no nurses. So anything you can do to avoid an ICU bed is very helpful, despite the fact that I want my ICU beds filled. So the primary endpoint at 48 hours was only 7 of 498 patients met the major adverse events. So there were 0 device-related deaths, 6 major bleeds, and 1 procedure-related adverse event. And note, none of the bleeds were intracerebral hemorrhage, because and the procedure-related adverse event was not device-related. And you can see again, all-cause mortality very low: 1 at 48 hours, 5 at 30 days, and 16 at 6 months. Next slide. As you can see, these numbers as we mentioned earlier, those numbers for mortality at 30 days and 6 months are vastly different than what we spoke about in the beginning of this talk. The great thing about clot removal is that you see on the table hemodynamic improvements. It's hard to know when to stop doing CDT if you're looking at these numbers, but in this data set, you can see there was a 23% decrease in the mean PA pressure on the table. And for those patients with low baseline cardiac index, which is 107 of the 500, you can see on the right, they had an 18% increase in index up to almost 2 on the table. And that's pretty fantastic. Next slide. Heart rate also dropped precipitously on the table, and patients who had improved a use of O2 from baseline to 48 hours. Next slide. You saw that 70% were on room air at 48 hours. The RV to LV ratio improved drastically as well, from 1.24 to 0.99 at 48 hours, with a 0.81 at the latest follow-up, which is not all the patients, but those that followed up. The RV systolic pressure improved from 48 down to 38 and then 30, and RV function also improved as well dramatically. You see at the end, by the end, very, very few have moderately or severely reduced RV function. Next slide. And then looking at dyspnea scores, those have also improved as well dramatically over the follow-up. Next slide. So just to finalize, we saw all-cause 30-day readmission. Oh yeah, readmission rate was also dramatic. And again, with ICU beds the hospital beds being the way they are, this is very important. Only 6% had readmission within 30 days, and only 6 of them were related to PE. And at 6 months, the patient, only 1.6% had CTEP and 1.5% had CTED, and that's dramatically lower than the quoted New England Journal article of 4%. Next slide. And finally, again, if you compare the mortality at 30 days, going back to here's the 1.3 for FLASH, versus what we saw in 5,000 patients with the PERT registry and the other 3 groups, dramatically lower. And again, readmission rate also dramatically lower, which was very interesting. And rates of CTEP are dramatically lower, though all of these things obviously merit further study and completion of the entire registry. Next slide. Let's go to the next one as well. So here's the final slide. This tells you everything you need to know about. Basically, these are real-world patients. It's fantastic procedural safety. The clinical improvements were seen on the table with drops in PA pressure, increase in cardiac index in those patients who were low, and decrease in heart rate. And then if you look at resource efficiency and long-term patient benefits, you also have dramatic improvements there as well. And this is a great slide just to kind of keep in your back pocket to refer to. Next slide. So then, the signal there, I kind of highlighted that those 31 patients with massive PE, because basically in the initial assessment of the first 230, 0 patients died. So to have a disease with a quoted mortality of up to 50% and have none of them die is astounding. So that to us, we thought was an interesting signal. It's not the end of the study, but it's an interesting signal that we should take a deeper look. So the next thing that happened was we started working on FLAME, which is flow retriever for acute massive PE. And the idea here is to evaluate treatment outcomes for high-risk PE patients treated with flow retriever versus kind of standard of care, with the ultimate goal is to change the guidelines. Because if we can get a mortality signal with massive PE, it's much easier to power a study with massive PE because the mortality rate is so high. So we're hoping we can really move the needle here with massive PE. So basically, this is a prospective, multi-center, non-randomized, parallel group observational study. So basically, there's a flow retriever arm, a context arm, and a prior therapy arm. And the primary endpoint is flow retriever arm looking at a composite all-cause mortality, bailout to a different device or ECMO, clinical deterioration, or major bleeding. So we're looking at up to 70 sites with 71 flow retriever patients, 71 context arm patients, and additional prior therapy arm patients to be included. And we've started enrolling last year, and we're going to follow patients up through hospital discharge. So we're hoping here, even with just 140 patients, that hopefully we can find some really dynamic results that can help us, as I said, move the needle on massive PE. And as I always joke, sometimes after working for months and months on trials regarding submassive PE, it's such a relief to switch over to massive or high risk because there's mortality, we can talk about mortality. So next slide. And then the super interesting follow-up to that is that besides doing these three registries, FLARE, FLASH, and FLAME, Inari has also announced the Peerless clinical trial, which is a randomized controlled trial of flow retriever versus catheter-directed thrombolytics and pulmonary embolism. This is very exciting. There's 550 patients to be enrolled, up to 700 patients, including the non-randomized cohort of up to 150 patients with absolute contraindications to thrombolytics, and looking at a primary endpoint of a new kind of endpoint called a win ratio, composited discharge, looking at all-cause mortality, intracranial hemorrhage, major bleeding versus ICH guidelines, clinical deterioration and bailout, and ICU admission and ICU length of stay. And patients will be followed through 30 days. So as you can see on the right, patients who are intermediate high risk PE, we've switched away from massive, I should have made that clear. So basically those that have absolute contraindications to thrombolytics go into the yes arm to the contraindication cohort. And then the ones that are not get randomized 1-to-1 to flow retriever arm versus CDT. And then basically there's the index procedure, there's a 24-hour visit, then follow-up hospital discharge, and then 30-day visit follow-up. Next slide. And that is it for me. But as I said, a lot of movement here in PE research. I think, as Vic said, Inari's been so dedicated to focusing on this in a way that other companies have not. And, for people like, I've only been at this for 10 years. I know Vic has been at this for much longer, but it's really nice to see some actual activity in the PE space. We're very excited to see how this changes patient care. Thank you.
Jim, thanks. That was an awesome presentation from the supply room. I think that's a first. That's fantastic. So a lot of cool stuff there. I mean, a lot of p-values less than 0.0001 for some of the data you showed, Jim. Again, I like the audience to think about Parth's case now. Look at those flash data. Think about Parth's case. I mean, I'd do that case whether there was a bleed risk or not. I also want to mention the flash data. We're going to have a publication coming pretty soon, the first cut of the flash data. Keep your eyes open for that data, because that'll be interesting data. Even though this will be 230 or so patients, even though we've got 800 enrolled now, the first cut's going to be there, and hopefully the next cut shortly thereafter. I'll finally mention that out there in the audience, if you got some Q&A comments, I see some starting to come in there now, and we'll try to get to some of these if we can. One quick question I'm going to answer right now. Keith Chan asked, go to him. For Peerless, why not include an anticoagulation only arm? It's a good question. I think one of the problems we have, and I have, as I've started to see these cases, and I've looked at them when they come in the hospital, is many of them I would not have equipoise randomizing them to anticoagulation. There may be some I would, but many I wouldn't. And any of the other, my colleagues have any thoughts about that? Why not an anticoagulation arm for Peerless?
No, I think I have the same concerns, right? I think the numbers that you showed and I think Jim showed, just even the intermediate high risk and intermediate low risk mortality, those numbers are unacceptable in 2021. So to me, like PE is a preventable, I keep on saying PE is a preventable disease. So it's very hard to randomize the patient just an anticoagulation arm, at least as all comers as a part of clinical trials. So no, I kind of echo the same opinion.
Great point. Some may be more comfortable if this was an all intermediate low risk patient. Maybe people would feel more comfortable with an anticoagulation arm. So good question, Keith. Thanks for that. Well, and again, Jim, thanks again for Flash, Flame, Peerless. A lot of exciting stuff coming, and we'll keep an eye open for the Q&A. So now we're lucky we got Rob Goldberg here, Pulmonary Critical Care down in Mission Viejo. Rob's going to present us a case, and it's an interesting case, a good case. Rob, looking forward to hearing from you here.
Thank you. The information's been really amazing, really interesting. Thank you both for sharing. So as Vic mentioned, I'm a pulmonary critical care physician at Providence Mission Hospital. Mission Hospital is in Mission Viejo, California. We're a community hospital. So sort of give what we're doing on the community side. This is not what our typical cases are. We've done over 100 cases at Mission, but this is one of our early cases and our most severe cases. So a 63-year-old female showed up to the ER with respiratory distress. She has a history of myasthenia gravis. Initially, the ER felt that she was in a myasthenia crisis and thought that her muscle weakness was leading to her respiratory distress. She was intubated by the ER physician and then immediately went into cardiopulmonary arrest. She was taken to the CT once they regained spontaneous circulation, and you can see on the CT scan, she had a quite large thromboembolic event. We joke around that this is a janitor CT, that the janitor's in the back of the room saying, man, that's a bad PE. So the CT was performed at 2:35 p.m. Her oxygen saturation at the time in the CAT scanner is at 50%. She's already going into this PE spiral of death, going into right ventricular dilation, tricuspid insufficiency, then your right ventricle starting to dilate, you're getting ischemia, your demands are going up, and you're starting to lose your cardiac output, your blood pressure starts dropping. Luckily, a cardiac anesthesiologist was available. She was taken to IR and a TE was inserted. Right femoral access was obtained immediately while the techs were preparing the angio table and equipment. The cardiac anesthesiologist was increasing pressors using the TE as guidance, and they did the first swoosh with the T24 at 3:01 p.m. So she was very lucky 26 minutes later to be able to be on the table and get that first swoosh. Here's her initial angio. You can see that there's almost no flow. The flow is almost stagnant, and what flow is there is not advancing into the pulmonary arteries. So at this point, her oxygen saturation continues to decline. She's now saturating 30%, and she starts going into a bradycardic arrest. Death is imminent. The anesthesiologist reports that the RV is no longer contracting on the TEE, and the initial injection into the main pulmonary artery, as you can see, is stagnant. The interventional radiologist does 8 immediate swooshes from the PA with removal of significant amount of clot, but also lots of blood. In full disclosure, the title of this presentation is Bloodless Thrombectomy. This obviously was not a bloodless procedure. This was one of the early procedures in which there was some blood loss, but now there's what's called the flow saver, which is a new device that's added on to the flow retriever, which significantly decreases the amount of blood loss to almost nil. Even during the flash data, I think if I remember correctly, the average blood loss even before the flow saver was about 200 cc's. This case was somewhat more dramatic, but with the flow saver, that amount of blood loss has significantly decreased. So immediately upon removing the clot, the TE shows immediate return of right ventricular contractibility and decreased dilation. Her heart rate comes up to 110. Her oxygen saturations increase to the 90s, and the patient regains color in her face. So this patient is now stabilized. We have a moment to sit back, take a deep breath, and figure out what the next plan is. So the TE shows a significant improvement in the cardiac function, but now the patient's somewhat volume depleted as the blood loss with the 8 swooshes. So fluid resuscitation is initiated. They use the flow retriever catheter in order to resuscitate the patient, as the anesthesiologist placed a IJ central line. Code hemorrhage was called, and the patient was given 4 units of blood and brought to, and the angio was reinserted. The patient was transfused, and the TE shows the patient is resuscitated, so they proceed with more selective thrombectomy to try and get as much blood clot out as possible. So you can see that here is the post thrombectomy images, and there's good blood flow to both sides, whereas before there was almost no blood flow. And here's the PE. It almost looks like a perfect cast of the pulmonary artery structures. Head CT was performed to assess for brain injury. That was normal. The patient is weaned from sedation and following all commands. She was extubated on post-op day 1. She was transferred to our step-down unit on post-op day 2, and she was discharged home on no oxygen on post-op day 4. A VQ scan was done 2 months later, which shows no perfusion defects. So this is a case that normally this patient would die without the ability to take out that clot. Even TPA would not have been fast enough likely to have saved this patient. But with the thrombectomy, we were able to reestablish flow, reestablish that right ventricular function. The other aspect that I really want to stress, and I know it's been mentioned a couple times, is patients that come in with large PEs normally would be admitted to the ICU, put on heparin, or another device would be placed and we'd have to monitor them in the ICU. We've been able to downgrade so many patients just by doing the thrombectomy that we're saving our ICU beds. They come in looking very, very ill, looking like they're on death's door. And once we remove the clot, their oxygen needs, their hemodynamics, everything improves, their PA pressures decrease, and we're able to save that bed.
Wow, Rob, great case. I mean, that CT angio looked almost incompatible with life. It's amazing you were able to save that patient in spite of the bleeding. And yeah, I think it's a great lesson for the topic of bloodless thrombectomy. Now that flow saver is available, the blood loss is down to 50 cc's, something like that, but a much lower amount of blood loss. In Flash, 260 cc blood loss per patient average, now much lower. So flow savers help. Quick, and so thanks for that great case. And a picture's worth 1,000 words, man. That clot extraction was awesome. There was a question in the audience that mentioned that we really need randomized trials. Enthusiasm alone isn't enough. And I agree with that, but it's hard to hold back the enthusiasm when you see a good case like that, but agreed. So like Jim said, we're moving on with Peerless, and that won't be the last randomized trial that Inari is going to do. So this is exciting. Any comments from my colleague before we move along?
Just adding to Vic, one comment. I think it's great I'm so excited because we are entering the world of RCTs in the world of PE. I think that was stagnant for 10 years, I think. So just to add to what you said, I think there is going to be randomized control trial looking at the CDT versus anticoagulation, suction versus CDT, which is our Peerless. And in European and North Canada studies, there is a low dose TPA and anticoagulation. So I think overall, enthusiasm is that we are taking the field.
Yeah, great approach. Any other thoughts, folks? And again, I'm going to remind the audience about think about who you might do when you see the Flash data again. I can keep reminding you of the Flash data. Would you do Parth's case, no bleeding, but suppose that patient was intermediate high risk, hadn't dropped his blood pressure yet, but was maybe tachycardic, heart rate's 125. I'd consider doing that case. I don't know. I like the ESC guidelines. I don't know if I want to wait till someone crashes before we act. So key point there. Well, Jim, I want to make sure we have time for Q&A at the end. I'm going to keep an eye on the Q&A box too. There's more questions coming in, but Jim, I'm really glad we got time for your last case. We might have to kind of blow through it to leave much time for Q&A, but Jim, man, talk fast and tell us about this case.
Yeah. Sure thing. And I mean, Vic, as you were saying, it's risk stratification, and it's not just, the invasive risk stratification that you can do once you're in the lab. Before that, I sort of glossed over the idea of echo, and there's several papers looking at echo findings like VTI, either LVOT or RVOT as a correlate for cardiac output. And there's even one small paper out of Penn that kind of has both the non-invasive and the invasive. But I think we're going to see an explosion of this in the short term, and probably more other advanced echo parameters that can be done at the bedside to help risk prognosticate. Because as you said, as we all know, there's lots of PE patients who look fine until they're not fine, right? They have that RV spiral of death that Rob showed. And once that happens, it's hard to get them back. It's hard to stop it. So clinically, what you look for typically on these kinds of patients is other high-risk features. People that have obviously both, imaging evidence of RV failure and also biomarkers. But again, looking at imaging, none of the guidelines talk about what if the RV to LV ratio is 2 to 1, or what if it's 3 to 1? That has to be worse in the great majority of patients, and as your LV is underfilled and can no longer get forward flow. I look for syncope. That always makes me think that this patient was 1 second away from a much worse outcome in their home. I look for persistent tachycardia. So, maybe the first heart rate of 110 gets you a point for S-PESI, and that's something, But the ones I worry about are the ones who are like 130, 130, 130. Those people are barely struggling to hang on. That heart rate is just staying up to try to give them some cardiac output. And so clinically, those are the folks that I worry about, that even though they're a high risk submassive, I might want to go sooner than not to do a procedure, because I don't know when they're going to decompensate.
Here's a great point.
So moving on.
I was going to say, Jim, I really hope we can maybe dig into the flash data, 800 patients, and maybe get a little more useful echo information about follow-up and things, all these parameters you discussed. So a lot we could still do with the registry data too.
Well, and I think, there's certainly, speaking to the rest of the pulmonologists in the panel, I mean, you guys do tons of bedside echo now. I mean, there's always pulm fellows asking me how to do TAPSE, asking me how to do VTI, and it's easy to teach. And a lot of them are probably already know, right?
Yeah. Hey, Jim, Palm Fellows. Yes, I think you brought a great point. I think we do I took the echo boards because I love PE and I need to do an echoes because I can get on board with my cardiologist because we talk the same terms. So every PE patient that we see, we put an echo probe in, and now I feel confident in my fellows can do RV, OT, VTI, LV, OT, VTIs, and identify the subclinical shock that you mentioned. So I think it's a great tool. Even the ESC guidelines recommend to use like 50-50 sign where you can look at the RVSPs and all that stuff. So I think we are shifting the paradigm with like doing more point of care echo along with the advanced ultrasound at bedside. So yeah.
Great point.
And for those of you who may not do it yourself, most techs, echo techs, as part of a standard TTE all across America, do an LVO VTI as a screen for aortic stenosis. So the waveform is there. You just have to have somebody trace it for you and give you the number.
Sure.
So that's my little pro tip. So we'll try to get this last case in quickly. Next slide.
Oh, Robert, you may have to advance the slide.
Yes,
thanks,
I can do that. Okay.
So this is an early a case that we had. It's a 44-year-old man with a BMI of 45, hypertension on Toprol 200 and amlodipine 10, hypogonadism on replacement therapy, comes in the right thigh and calf pain for 6 days, thinks, as people often do, oh, I just overdid it. I was in the yard work. I was doing something. I had to pick up my kids. But you can see his blood pressure, when he first gets here is 130 over 116. This narrow pulse pressure always worries me. His heart rate is persistently tachy, not the 130s that I mentioned, but certainly over 100. He's 88% on room air. Oxygen did not improve with 6 liters. Ended up on high flow nasal cannula 80% at 30 liters to get a SAT of 95. Next slide. So here's his basic labs. Nothing too exciting. Creatinine is normal. Next. Next slide. And here's his, that was his EKG just to show sinus tachycardia and a little S1Q3 T3 action. Here's his CT, as you can see, extensive clot. The RV is probably 1.5 size the LV. And then a couple little tidbits. So number one, we saw that he is on Toprol and amlodipine, both high doses of both. And his blood pressure is normal, 120 over 110. But you always ask the patient, did you take your medication today? And half the time they say, no, I felt crappy, so I didn't take it. And so this person is potentially relatively hypotensive. If he's on those 2 meds, his blood pressure should be like 160 if he didn't take them that day. You can make the argument at least. Number 2, you see contrast reflux into the IVC. And it's another indicator of poor RV function. That always worries me. And then lastly, just for fun, because I'm a cardiologist, you can see coronary calcification in the LAD territory. So I wonder if he could get ischemic if we get sicker. And just to nerd out, I'll point that out again. It's right there. All that, you saw that calcification. Next slide. There it is. This is the left main and LAD. Next slide. And obviously significant PE. And you can see here's his echo with an enlarged RV outflow. It doesn't look like it's moving that well, but you can see whenever the color is turned to something non-black and white, it means it's a technically difficult echo, probably because of his BMI. Next slide. And here's the peristernal short. If it runs well, you could probably convince yourself there's some Dean, but it's not really running right now. And then next slide. There we go. The apical four chamber is much better. That RV looks more like twice the size. So again, the guidelines just say RV bigger than 0.9 of the LV, but what do you make if it's twice the size? And is that person at higher risk of decompensation? Next slide. And then additionally, he had, as we saw in FLASH, 2/3 of patients had lower extremity DVTs. So here's a occlusive DVT with compression. You can see over here on the right side. Next slide. And so in the end, we decided based on those numbers to move ahead with procedure. We felt that he was borderline and could decompensate. You can see the angiogram here. There's a just giant meatball here of thrombus. Next slide. And here's the zoomed in for people who don't look at a lot of these angiograms. You can see that big white opacity on the right side. Next slide. And to make a long story short, here's a nice clot haul, not as much as Vic's original pictures, but you don't have to be perfect to get patients out of danger. So a significant portion was taken out. He still has some residual, but you can see he has much better perfusion for his lung, for the right side. And then we can just kind of flip through these quickly. And in the end, his echo was started to improve. Robert, you want to just keep clicking through in the interest of time? Sure. So his echo improved, and then his leg was still swollen. So a couple of days later, his leg was still swollen and red. So a couple of days later, he actually got ClotTriever as well. And he followed up with the PERT clinic, did well. We switched him to DOAC, and we were waiting a 3-month follow-up echo to see if that RV dysfunction totally resolved. And he recommended 6 months of DOAC and no hypercoagular workup because his risk factor was the meds for his hypogonadism.
Wow, Jim, great case. Yeah, I would argue with this guy, since he's morbidly obese, I'd probably treat him long-term at 6 months, drop his DOAC dose in half. I might disagree with him there, but whoever sees him up. But wow, what a great save, Jim, and a couple lessons there. We didn't get a chance to talk about DVT very much. We've seen some pretty impressive DVT cases lately. Some Q&A have come in. We've answered some of the Q&A, but any thoughts? I'm going to open things to the panel right now, and we're keeping an eye open for some Q&A here.
No,
well, another tip for him that I glanced over was that the reason he was so hypoxic. So another PE pro tip: if they're that hypoxic, they have a PFO. So he ended up in high flow, and then they saw the PFO later on the echo and did a bubble study. And then the question you have to ask for yourself is, would you close that PFO because of the risk of embolizing to the left side if you were to have a PE again?
What do you guys think about closing the PFO? Those are always tough. I mean, most of these, 1 in 5 of us has a PFO. If there's not something funny about the septum or a really high right-sided pressures, maybe the right-sided pressures, if they're in the 50s to low 60s, like they usually are the QP, maybe we don't see stuff go across, but we certainly have before. Anybody have strong feelings about closing the PFO?
Yeah, I mean, usually we don't. In setting up acute PE in a state, it acts as a ball valve mechanism, right? I mean, same thing we talk about even in state PH, that closing the PFO may make things worse. So in acute setting, probably not. I mean, unless patient goes for surgical embolectomy, that's the only case you would close a PFO, because you are in there, heart is open, you can close it. So
great.
There was a question on the chat, which was comments about starting FlowTriever in stable patients. I'll say that at our facility, we've done it on multiple stable patients. Usually they show some signs of right heart dysfunction, and how we're evaluating the patients is we're checking troponins, cardiac enzymes, we're checking the BMPs, looking for those biomarkers, signs of cardiac stress. We're looking at the EKG. We are able to get echoes fairly quickly. The other aspect that we have trained our radiologists that on the CTAs, whereas they didn't used to measure the RV to LV size, they're now standard fashion measuring those and commenting on the LV to RV size, so we can see what the ratio is and help us make the decision about whether to proceed with FlowTriever.
Great points, Rob. Great points. Somebody asked a question earlier about whether you can do a patient, if you could FlowTriever a case that couldn't be anticoagulated. That was like Parth's case. I mean, you certainly can. It's always nice to be an anticoagulate when instrumenting somebody, if you can. Obviously, anticoagulation reduces mortality. We want to anticoagulate PE patients, but if you can't, there's still options. Somebody also mentioned something about low platelet counts. Anyone have strong feelings about a degree of thrombocytopenia would make you say, I can't do this case? Or would you transfuse in platelets? Or what would you guys say? Any thoughts?
Yeah, so I think degree of thrombocytopenia obviously makes you worried, but you can always transfuse and do the procedure. The way I see it is like a collateral damage, right? You are in a war zone. You have a low platelets and you have massive PE. Old days, I mean, Vic, you know that, and you talk about it. If the platelets are even 25, and if you had to give TPA, you give TPA and worry about the bleeding later. This is much safer stage to deal with. That you give them platelets or infuse the platelets and you do the procedure, because we know all the blood products are transiently remain in the system. So yes, we had cases where infusing the blood products or platelets or FFPs, and we are still going through the cases because that's what's going to kill your patient.
And we always think about HIT, with the platelets low, because sometimes it's consumption. You have a big PE, consume platelets, the platelet count might be 95,000 from big PE, but I got to think about HIT. That's disastrous not to realize that.
Yeah, and I have used the TEG, and I'm sure Jim and I think all of us who work in CACU use the TEG also. So sometimes it's just the numbers, and platelet function may be fine, and you are just worrying for not reason. So maybe use TEG in those borderline cases where numbers are at borderline. So.
Yeah, great thought. Yeah. Anyone have thoughts about the learning curve? Someone asked about the learning curve here earlier. How many cases do you need to do? I'm going to say this before we answer. A shout out to the Inari reps in the field. They're an amazing bunch of people who, some of these folks have done 100 cases, scrubbed in 100 cases, we've been in 100 cases, and offer great advice on the toolkit, what's available, have tremendous experience here. But how many cases does someone need to do before they're proficient, you think? Any ideas?
I think I would say I'm not an interventionalist, but I think all our IR folks after 5 cases felt extremely comfortable. So
I would say 5 to 10 probably is reasonable to kind of get there, and for sure, yeah.
Yeah, absolutely. When I was speaking to our interventional radiologist, Dr. Burns, he said the learning curve is extremely steep. After 5, he felt very comfortable. The advice was don't take one of the cases like that we presented, which was a life and death, as your first case. Do some low-hanging fruit early on to get used to the device. Obviously, if that's the only option for someone, it's a matter of life or death, you might take the risk, but the learning curve is extremely steep.
Well, that's a great bullet point. Yeah, try not to do the crashing massive PE patient as your first case. Another question just popped up as we update our PERT algorithms with suction thrombectomy. Question always comes up: when would you still do catheter-directed thrombolysis? Any thoughts there, folks? About a case you might still do catheter-directed lysis in?
So I don't think I've seen one. I haven't seen one recently.
Yeah.
Since we've been doing suction thrombectomy, we haven't needed to do them.
Yeah, and I think audience question, in respect to that question, I think that's why we are doing the trial, right? That's what all the Peerless is about, and I think that's what the RCT is going to answer. Only one thing, if I had to think out very loud, is that if I have like showered off PEs, right? So if my PEs are completely showered off and I can't give systemic TPA and there is no proximal clot at all, maybe CDT, maybe fall into that category. But apart from that, I think that's why Peerless is going to answer.
I occasionally see people who feel like a patient's so hypoxic they can't lie flat and they don't want to intubate them, so they'll access from the neck and do CDT.
Mm-hmm. A good point, Jim. Yeah. I think the advantage we're thinking of as we do Peerless is, we have a technique we can do and get immediate results. We don't have to wait 6 hours, 8 hours, 10 hours, however long you do CDT, which is great. And often, like I think Rob pointed out, and you did too, Jim. You often don't need an ICU for these cases. If you do, it's brief, and you do sometimes a really sick patient for sure. But with CDT, in most hospitals, you have to have an ICU bed, which is not so easy nowadays. Well, yes, we're wrapping things up. We've got a couple of minutes left. Any last minute thoughts? I think it's been a great presentation by all you guys. Gave us some superb, sort of diverse, cool cases. They're impressive. Any thoughts? Again, I'm going to say it again. I don't want to be redundant, but if folks out there, Google the TCT data. Jim's presented the data before. Kyle and Toma presented at TCT in November. The first 500 patients. Look at those data. I think it's hard to imagine. It's a registry. It's not a randomized trial, but the results look so good. It's hard to imagine another arm could look better. I'd love to hear other thoughts about Flash from folks. So if you haven't seen the data yet, Jim showed them to you. He flashed them by. If you haven't seen them, Google those data and take a look at them.
Well, Vic, I would just add on to that and say, when people, there's a question also from the group about, how do you do this for somebody who's not hypotensive, based on guidelines? And I think the answer is, in cardiology, every guideline that I have is based on, these trials of 10,000 patients. Every stent trial is 10,000 patients, you know, and in the PE, we have these trials of like 80 patients. I mean, if you look at the total number of patients who've been in any CDT trial, registries, small industry trials, it's like 300 patients or 400 patients in total, right, Vic? That's it.
Yeah.
And so the guidelines don't represent any real great fund of data. And, you know, if you see enough patients decompensate and you say to yourself, well, you know, the guidelines don't have class 1 data, class 1 indications for X, Y, and Z, but this patient looks sick.
Yeah.
They syncopize, they look like crap, they're hypoxic, you know, and you've seen enough of them. You know, you go home at night, you come back and you find out they coded. You know, if you see patients like that, you sort of get the sense of it. And then once you start looking at these numbers from FLASH and seeing that when you put the catheter in and their cardiac index is 1.7, you got to think there's more to it than what we have now. And it's not that you should slam dunk do an invasive procedure for everybody, but you should think about it and should really think about, you know, joining a trial and joining a randomized trial if you have a site that is proficient in this device, and keep your eye out for more randomized trials from Inari and from others.
Absolutely. We got great safety data. We say first, do no harm. But you showed us great safety data, Jim. So I think, do we want to go by the ESC guidelines, which are great guidelines in a lot of ways? They emphasize the role of PERTs, things like that. But they say, wait till someone deteriorates and then try to figure out what to do. And in some cases, you know, if they're very stable, it's one thing. But I think look at the intermediate risk patient mortality rate. And let's think about this. I think Peerless is going to teach us some stuff. And as we analyze the final data from FLASH, we're going to learn a lot. But it looks like a safe procedure. So more to come with more studies, like you said, Jim. Parth, Rob, any last words?
Yeah, the other thing I'd just like to say is that there's probably so many patients that have subclinical shock that we're just not recognizing. In fact, we just discharged a patient today who came in 2 days ago, 91 years old, came in with a large right side PE. He looked fine. The main issue was he was on 5 liters of oxygen, where his baseline is 0. Troponin really wasn't elevated. BNP was slightly elevated, but he had a large clot on CTA. So I discussed this with our interventional radiologist. We took him to thrombectomy. And when he inserted the FlowTriever, he checked his PA pressure, and his PA pressure was through the roof. It was like 45, 48. He did the thrombectomy and it immediately dropped to 26. This is a 91-year-old gentleman who was a healthy 91, but his heart would not have liked having that type of pressure for an extended period of time. So saying that the patients are completely stable, I don't completely agree with, because I think we're just not recognizing how sick they are.
Sure. Yeah. And again, one of the attendees mentioned this issue of how do you reconcile taking a patient without hypotension for thrombectomy. I've kind of talked about that some. The easy ones are heart rate of 120, 130. To me, that means your RV is just doing its best. It's not built to do well. And do we really want to wait till someone crashes and then say, what do we want to do? To me, it's kind of like the parachute. We're never going to do the parachute study. We're never going to do a randomized study to see if parachutes work. At least I'm not going to be randomized in that study. Now, of course, that's a little extreme, maybe. It's a little extreme. I mean, that doesn't apply to all studies. We certainly want randomized trials, there's no doubt. But I think there's many patients that some of us would not have equipoise with randomizing in an anticoagulation trial. These hypotensive patients or these borderline cases, it's sort of a artificial definition. Systolic blood pressure less than 90. If it's 91 or 92, you may have high lactate. You may have already had syncope. You know, your cardiac index may be low. Well, guys, what a great hour to spend with you guys. I'm going to say one more time. Any last thoughts? I hope we can do another one of these at some point.
I have one plug for the PERT Consortium.
I love it. Yeah, we love PERT. We have to shout out to PERT. PERT's helped us so much get things organized. They got a great registry, a great team, doing a lot of really good things. So we have to shout out to PERT and to ACCP for helping us lead the way in PE. So thanks, guys. Great to see everyone. And I hope we can do this again.
Thank you.
Take care.
Thank you.